My name is Jasmine Leonard, and I did my presentation on end of life care. The objectives of my presentation are to name the top leading causes of death, define what end of life care is, differentiate between supportive care versus palliative care, discuss legal issues with end of life care, discuss the difference in physician assisted suicide versus euthanasia, name various end of life cultural preferences, discuss what hospice does for the patients and the services which are provided by hospice, name important aspects of good end of life care, discuss the 5 stages of grieving, and discuss Orlando's theory in correlation to the end of life. The top leading 10 causes of death that I found were heart disease, cancer, chronic lower respiratory disease, strokes, unintentional injuries, accidents, Alzheimer's disease, diabetes, nephritis, nephrotic syndrome, and nephrosis, influenza and pneumonia, and intentional self harm, such as suicide. End of life care can be defined as the care that helps those with advanced, progressive, incurable illnesses to help them live as well as possible until they die. The end of life care is about the total care of a person with an advanced, incurable illness and doesn't just equate with dying. The end of life phase may last for weeks, months, or even up to years. Supportive care is defined as the care that helps the patient and their family cope with their condition and the treatment from pre diagnosis all the way through diagnosis and treatment to cure, continuing illness, or even death and into bereavement. An example would be a person that receives supportive care for a variable amount of time, which is not anticipating death. Now, palliative care is the active total care of patients whose disease is unresponsive to the curative treatment. The goal is to control their pain and their other symptoms and to support and manage the psychological, social, and other problems which are present. And the goal of palliative care is to achieve the best quality of life for the patient and their families. Some of the legal issues that I found, which is commonly a big deal on our floor, especially in my hospital, is the legal documentation side of it, which will tell you what the patient's wishes are and what they want to be carried out at the end of life. They have the advanced directives, which is also commonly called power of attorney, DNR, or a living will. The advanced care directive is specific instructions which are prepared in advance that are intended to direct a person's medical care in the case that they are unable to do so in the future. Some of the examples of advanced directives would be verbal instructions, which are verbally communicated by typically a family member or a spouse, which kind of dictates the individual care that the healthcare provider should provide. Organ donation, a living will, which would be a written legal documentation which states the person's wishes in the event of a serious illness. Special medical power of attorney, which is a legal documentation that appoints a certain person or persons to make medical and healthcare decisions in the event that the patient is unable to do so personally. And a DNR, which is commonly heard of in the hospitals, is a do not resuscitate order, which basically states that they don't want any type of cardiopulmonary resuscitation to be performed on them. If their heart were to stop or their lungs were to stop working, they just want to be done. They don't want any special interventions. Another interesting legal issue that I saw in a few of the articles and websites were the difference in the basically whether physicians should be allowed to intentionally kill their patients by possibly providing means of death or even ending the patient's life themselves. There was a big deal with some of the terminology, the medical technology that will basically stop the dying process, and if the patient should be allowed to die naturally. And they have different terms that they've used commonly throughout their research that I found: the physician assisted suicide and euthanasia. They normally would be used interchangeably, but they mean totally different things. The physician assisted suicide is basically the medical doctor providing the patient with the means to kill himself, which could be used as an overdose of prescription medication that would assist him, while euthanasia is typically defined as the intentional killing of a patient by the direct intervention of a physician, which is for the good of the patient and others. Most commonly, the most common form of euthanasia is lethal injection, which is seen a lot in prisons, people who get death row, things like that. And euthanasia can be administered voluntarily, which will be by the patient's wishes, non voluntary, which would be without the patient's consent, or even involuntary, which would be against the patient's actual wishes. Euthanasia, I'm sorry, um, physician assisted suicide is legal in only 3 states so far: Oregon, Washington, and Montana. The 47 other states, including the District of Columbia, assisted suicide is considered illegal. And in those 47 states, the punishment can range from a felony charge to first degree murder. In all 50 states and the District of Columbia, euthanasia is prohibited under the general homicide law. So it's considered homicide. Euthanasia is. Some of the cultural preferences with end of life that I found were pretty interesting. According to this article that I found, the Arabic Muslim culture generally feels that family should take care of the individual. They prefer to be at home with family and don't really like hospice placement. They feel that having a living will is very important, and they're pretty much against assisted suicide. The Arabic Christian culture generally does not feel like you should talk about death in advance, and they feel that family should take care of the individual, and they feel that spirituality is very important. The Hispanic culture prefers to die with dignity and good care. The males typically want little medical intervention and prefer help with ending their life, while the females are generally the opposite. They prefer extensive medical intervention and are against pulling the plug. The African American culture generally feels pretty comfortable with going to a hospital or a nursing home placement, and the males typically don't want everything possible to be done to maintain their life. They don't want family to take care of them, and they're pretty distrustful of the physicians. While females generally want everything possible done to help maintain life and are against the assisted suicide idea. The Caucasian culture generally wants to know what to expect. They want to know what the plan is, they want to know what you're going to do. They generally prefer to die at home, and they feel that age discrimination does exist. The males typically do not want their family to take care of them, but they want their family to be present, while the females want to make their own decisions and prefer to have no pain during the end of life process. Hospice is a really common term that is heard during the end of life care. It is generally associated with end of life. If a person is in that stage where they're in the end of life, they usually have hospice unless their culture is against it or they're personally against it. But what hospice is, it's an end of life care service that is provided by health professionals and volunteers that can offer medical, psychological, and even spiritual support to the patient during this process. The goal of hospice care is to help people who are dying to have peace, comfort, and dignity during the end of life phase. The caregivers typically want to control pain, which is one of the biggest issues with end of life care is controlling the pain, along with other symptoms so the person can remain alert and as comfortable as possible. The hospice programs also provide patient and family support. They provide grieving services, they provide support. They can also recommend support groups that are available, and they're just a wonderful service to have. A patient can go through hospice if they have 6 months or less time left in their life expected. The hospice care can take place at home, in the hospital, at a hospice center, or even in a skilled nursing facility. Some of the important aspects of good end of life care that I found are communication. The patient wants to know, what to expect, and it's good that the care provider as well as the patient are on the same page as far as what to expect from the care, what can they get out of the care, what do they have available to them. It's also important to communicate and to understand how the patient is feeling. This is a difficult time in the patient's life, and they may have a bunch of different feelings going on. They may have a bunch of different issues. So it's pretty important that the care provider answer questions and kind of help the patient through the process to help them be comfortable as possible. It's also important to also focus on the family. How does the family feel? Do they need any help with coping with the end of life phase? Do they have any questions? What should they expect as far as the care that will be provided to their family members? So that's pretty important to have that communication going on. Nutrition is also important. Know what foods the patient can tolerate so that they continue to have a decent and quality amount of nutrition and food intake. Pain management, is great to have appropriate pain management. What can the patient tolerate? What medications help the patient? Is there a need for increase in pain medication, decrease in pain medication, or alterations? Um, it's also good to use non pharmacologic methods such as heating, cooling, soothing things, music, relaxation techniques, things like that that can help to maintain the comfort and quality of life. Um, Also, finding support for the family, grieving counseling, support groups, just conversation that they may have, questions that they may have that they need answers, just being that support for them. And also, advanced planning. With it being the end of life, it's important to know what the funeral arrangements are. What funeral home does the patient plan to use? What are the wishes for the patient at this end of life phase? I felt of all the different crises in the readings that we had, I felt that uh, the individual that is going through the end of life phase could possibly be having a situational crisis because it's specific to the situation of the patient. It is uncommon. In most cases, it may be expected, but typically it's uncontrollable. It's things that they can't control, like they don't have the cure for anything, or there's nothing more that the physicians can do. And it's pretty uncommon because you only go through the end of life phase one time, generally. It can occur at a sudden illness, things like that. And it's usually pretty shocking, intense, and catastrophic to the person. I found it interesting, and I found an article on the Kubler-Ross model, which is deeply correlated to helping the patient as well as family members through the grieving process that they will experience and typically experience during the end of life stage. Um, this was developed in 1969 by Dr. Elizabeth Kubler-Ross, which was published in a book. And it went through the 5 stages of grieving, which are denial, anger, bargaining, depression, and then ultimately acceptance, which would be basically equivalent to the patient adapting to the end of life phase that they are experiencing and understanding that it's inevitable and, kind of adapting to the situation and being able to handle it. For nurses and care providers, it is really, I found it really, really, really important for them to kind of apply the Ida Jean Orlando's nursing theory, which basically says that the role of a nurse is to use her own perceptions to find out what the actual individual needs are of the patient. This theory is used with the end of life patient to find out what will bring them comfort, both physically and emotionally, and looks beyond just what the patient states. It looks at their emotions, it looks at their body language, which is really important, the nonverbal as well as the verbal. The theory expands on the basic medical care of the patient by the nurse and also focuses on the multi-dimensional role that also goes to the holistic patient. It deals with the whole patient as a whole, not just the basic medical care that the patient needs at that time. The theory is ideal for nurses in the end of life phase as well as nurses, period. It's a very, very good model to go by during this phase. Um, the Roy's adaptation model, which was developed by Sister Calista Roy, it represents the holistic patient, holistic adaptive system that kind of interacts with the internal and external environment. And the ultimate goal of the nursing is to foster the the successful adaptation of the patient. Is to ultimately the goal of looking at all the different adaptive modes and major concepts is to ultimately help the patient adapt to the situation. Um, the best mode that I found pretty important with end of life care was the self concept. What does the patient what does the patient feel? How are they psychologically? How are they spiritually? What are their feelings during this stage? What are their beliefs? What are their concerns? Things like that. Helping them understand what's going on, cope with what's going on, look more into their personal beliefs and their feelings that they feel about this can kind of help them work through and eventually cope with what's going on so they can end up ultimately being the most comfortable that they can be. And the nurse can also ultimately provide the most comfort to the patient. Um, and there I listed the whole Roy's adaptation model as well as the major concepts. Adaptations, which are the goals of the nurse, which the goals of the nurse ultimately have to be correlated back to the expectations of the patient. The person, their adaptive system, how do they adapt, what do they expect, how can you help the person work through and eventually adapt to the situation and be okay with what's going on. The stimuli and the environment, the health outcome of adaptation, what's the ultimate outcome, and then the nursing, which kind of promotes the adaptation for the patient as well as the health status of the patient. And that was pretty much my presentation on end of life care, just ultimately communicating with the patient, understanding what they're going through, helping them ultimately work through the grieving process, and making sure you take care of the patient as a whole, not just focus on the basic needs of the patient, but as a whole. and be there as a huge support through this time, as well as providing comfort during this stage and making sure that the person ultimately, as well as the family, ultimately adapts to the end of life phase. And I also chose for my class interaction, I didn't want to do a quiz or anything. I actually chose a end of life care video that kind of explains some of the palliative care and the responses by the family members that were present during that time, that kind of explained how they felt and pretty much supported the idea of the end of life care phase and the care that they are getting provided by the healthcare professionals. It is the end of life care. If you go to YouTube and type in end of life care NHS choices, it is a video which is only a few minutes, but I thought it was a very wonderful video, and very appropriate to my presentation. And my last slide has my references, which I retrieved all my information from. Thank you.